Two patients arrive at the same hospital within minutes of each other. Both are critically ill. Both need the same intensive care bed. Without it, either patient may die. One patient is 28 years old. The other is 78. There is only one bed. Who should receive it? If your immediate answer is the younger patient, you are not alone. Many people believe that saving the younger person preserves more years of life and gives someone who has had less time a fair chance to experience adulthood, family, work, and old age. If your immediate answer is that age should never matter, you are also not alone. Many people believe every human life has equal value and that using age turns older people into second-class citizens precisely when they are most vulnerable. This is not a puzzle with a painless solution. If the hospital gives the bed to one patient, it is not simply choosing whom to help. Under true scarcity, it may also be deciding who will not receive the best chance to survive. The question becomes even harder when we change one detail. What if the older patient has a 90% chance of surviving with intensive care, while the younger patient has only a 10% chance? What if their chances are equal? What if the younger patient has a severe chronic illness? What if the older patient is the only caregiver for a disabled spouse? What if one patient arrived 5 minutes earlier? Every extra fact pulls our moral instincts in a different direction. Before deciding whether hospitals should prioritize younger patients, we need to distinguish ordinary medical decisions from crisis allocation. In normal conditions, doctors recommend treatment according to each patient's medical needs, likely benefit, informed wishes, and available options. A hospital does not usually remove one suitable patient from an intensive care bed merely because a younger person arrives. Scarcity changes the situation. During a disaster, epidemic, war, mass casualty event, or severe staffing collapse, the number of patients who may benefit can exceed the number of beds, ventilators, medicines, organs, or trained professionals available. Then medicine is forced to confront a terrible fact. Giving a resource to one person means that it cannot be given to another. This problem did not begin with COVID. In the early 1960s, long-term kidney dialysis became possible in Seattle, but there were far more patients than the small program could treat. A group of community members was asked to help decide who would receive dialysis. The group later became known as the Seattle God Committee. Candidates first passed a medical review. The committee then considered personal and social information, including work, family roles, income, education, and perceived value to the community. People were effectively being judged not only by whether dialysis could help them, but also by what kind of life the committee believed they had lived. The controversy became one of the events that helped shape modern bioethics. It revealed the danger of allowing hidden social preferences to decide whose life is worth saving. Today, the American Medical Association says scarce resources should not be allocated according to social worth, a patient's perceived contribution to illness, past use of resources, or other non-medical characteristics. That sounds clear. But age occupies an uncomfortable space between medical and social information. Age can affect survival. It can be associated with frailty, organ function, recovery time, and the presence of other illnesses. Yet age is also a personal characteristic. Two people of the same age can have completely different levels of health. Using age as evidence about prognosis is not exactly the same as declaring that a younger life is worth more. But in practice, the two ideas can easily become confused. The COVID pandemic made this conflict visible around the world. In March 2020, hospitals in northern Italy faced an extraordinary surge of patients with severe respiratory failure. The Italian Society of Anesthesia, Analgesia, Resuscitation and Intensive Care published recommendations for exceptional circumstances in which needs overwhelmed available intensive care resources. The recommendations emphasized the chance of survival and the goal of saving the greatest number of lives. They also said it might become necessary to consider an age limit for intensive care and to consider the number of life years that could be saved. The public reaction was intense. Supporters said the document honestly confronted choices that exhausted clinicians were already facing. Critics feared that older people, people with disabilities, and those with chronic illness would be treated as less worthy. Later analysis emphasized that age, other illnesses, and functional condition should be assessed together rather than using age as an automatic exclusion. In Britain, Early COVID guidance recommended use of a clinical frailty scale to support decisions about critical care. Concerns quickly arose that a tool designed mainly for older adults could be misapplied to younger people with stable disabilities or learning disabilities. Guidance was clarified so that clinicians would use individualized assessment where the scale was not appropriate. These events show why a simple rule can become dangerous. A policy may be written to predict medical benefit. At the bedside, it may become a shortcut that labels a whole group as less deserving. Let us examine the strongest argument for giving some priority to younger patients. It begins with the idea of life years. If two patients are equally likely to survive treatment, saving a 28-year-old will probably preserve more future years than saving a 78-year-old. A health system trying to produce the greatest total benefit may consider that difference morally relevant. Supporters sometimes use the idea of a fair innings. The argument is not that an older person's current life has less value. It is that the older person has already had opportunities to pass through life stages that the younger person has not yet had. When unavoidable tragedy prevents everyone from being saved, giving some priority to the person who has had the least chance to live a complete life may seem fair. There is an important difference between saving the most lives and saving the most years of life. Suppose one policy saves 10 people who are expected to live 5 more years each. Another policy saves 8 people who are expected to live 20 more years each. The first policy saves more people. The second preserves more total years. Neither calculation is morally empty, but they answer different questions. A system that counts lives treats each survival as one success. A system that counts years gives greater weight to people expected to live longer. If the public has never agreed which goal matters, a hospital should not quietly choose one during a crisis and present it as pure medical science. Age priority also raises the question of how much difference should matter. Should a patient who is 60 receive priority over someone who is 61? Most people would say no. What about 40 and 80? The larger gap changes intuition, but any formal rule still needs a boundary. Hard cutoffs create dramatic consequences for people separated by a single birthday. Flexible judgment avoids that cliff, but it can produce inconsistency and hidden bias. Imagine 2 people with equal medical need and exactly the same chance of survival. One is 18, the other is 88. A lottery treats them equally at the moment of decision, but does it treat their lifetime opportunities equally? The 18-year-old has barely entered adulthood. The 88-year-old has had 7 additional decades. Some people feel that ignoring this difference is not neutrality. They believe it ignores a profound inequality in the amount of life each person has experienced. There is also a practical argument. During severe scarcity, policies must be understandable and usable. Doctors cannot conduct a complete philosophical biography of every patient. Age is easy to measure and is often recorded accurately. But simplicity is not the same as justice. The strongest argument against age priority begins with equal human worth. An older person is not a life that has already been spent. That person still has relationships, plans, responsibilities, pleasures, fears, and a claim to dignity. The remaining year of an older person's life is not less real because a younger person might have more years ahead. Age cutoffs can also disguise uncertainty. Doctors are not able to predict an individual future with perfect accuracy. A healthy 80-year-old may recover quickly. A younger patient with severe organ failure may have little chance of surviving. If age replaces careful prognosis, resources may be used less effectively, not more. Then there is the problem of discrimination. Older adults have spent lifetimes contributing to families, workplaces, communities, and public systems. A rule that reduces their access precisely because they survived into old age can feel like society withdrawing membership at the end of life. The American Geriatric Society has argued strongly against using age alone to exclude anyone from care. It recommends focusing mainly on the chance of short-term survival, assessing other illnesses carefully, avoiding crude life year calculations, and using transparent triage committees rather than forcing frontline clinicians to make isolated decisions. There is another inequality hidden inside life expectancy. Life expectancy is shaped by poverty, discrimination, dangerous work, environmental exposure, disability, and unequal access to healthcare. If a policy favors people predicted to live longest, it may repeatedly favor groups that already had better conditions. A rule that appears mathematically neutral can therefore deepen existing injustice. Prioritizing younger people can also slide into judging social value. Someone may argue that a younger patient has children, a job, or more economic productivity ahead. But an older patient may care for grandchildren, support a spouse, volunteer, teach, or hold a family together. Once hospitals begin measuring whose future is more useful, they recreate the moral danger of the Seattle Committee. Human beings become resumes. What alternatives exist? The first is to prioritize immediate medical benefit. Doctors can consider who is most likely to survive the acute illness with the scarce treatment. This approach aims to save the greatest number of lives without directly ranking people by social status. Yet prognosis is never perfectly objective. Scoring systems may contain bias. Chronic disability may be mistaken for poor short-term survival. A patient who looks frail may still respond well. Clinical judgment must therefore be reviewed and updated. The second approach is urgency. Treat the person in greatest immediate danger first. That fits the rescue instinct at the heart of medicine. But it can direct resources towards someone unlikely to survive, while another patient with a much better chance loses the opportunity. The third approach is first come, first served. This appears neutral because it avoids judging age or worth. But it favors people who live closer to hospitals, have better transport, recognize symptoms earlier, or already have access to the health system. It can also encourage a rush for resources and leave no flexibility when a later patient has far greater need. The fourth approach is a lottery among patients with similar medical prospects. A lottery recognizes equal moral worth and avoids pretending that tiny differences in scores are scientifically certain. It is especially defensible when patients have genuinely similar chances of benefit, but many people find random selection emotionally difficult when the likely years of life are very different. The fifth approach combines several principles. Medical teams first exclude patients who cannot benefit from the treatment. They then prioritize the chance of surviving the immediate illness. If patients remain closely matched, a limited life cycle consideration or lottery may be used as a final tiebreaker. This avoids making age the first or only rule. It does not eliminate tragedy, but it makes the reasoning more proportionate. The World Health Organization has emphasized that different resources may require different allocation principles. Age may be relevant when it changes the expected medical benefit, but using age alone can be discriminatory. When patients are expected to benefit equally, equality-based methods such as a lottery may be appropriate. Process matters almost as much as the chosen principle. A good crisis policy should be written before an individual case creates panic. It should be public, medically informed, legally reviewed, and open to criticism from older adults, disability advocates, clinicians, ethicists, and the communities it affects. The treating doctor should not carry the decision alone. That doctor has a duty to advocate for the patient. Asking the same person to withdraw care for the sake of population benefit can cause unbearable moral conflict. A separate triage team can apply the policy consistently while allowing the bedside team to continue caring for the patient. Decisions should be reviewed as the patient's condition changes. A person denied an intensive care bed should not be abandoned. Pain relief, oxygen where available, nursing care, communication, and compassionate support still matter. Scarcity changes which treatment can be offered. It does not erase the duty to care. There should also be an appeal process for obvious errors. An appeal cannot become so slow that the resource is unusable, but patients and clinicians need a way to correct mistaken information, an inappropriate score, or misapplication of the policy. So, should hospitals prioritize younger patients? My answer is that younger age should never create an automatic right to treatment, and older age should never create an automatic exclusion. The first question should be medical. Who is likely to benefit from this resource now? Who has the better chance of surviving the immediate crisis? If one patient has a clearly better chance of survival, that difference can ethically guide allocation, even when the person with the better prognosis is older. If two patients have truly similar prospects, the moral disagreement becomes sharper. In that narrow situation, I understand why some people support a limited life cycle tiebreaker. They are not necessarily saying the older person has less human value. They are trying to give each person a chance to experience the stages of life. I also understand why others choose a lottery. They fear that once age enters the formula, equal citizenship disappears. Reasonable people can disagree about that final tie. What is not reasonable is a secret rule, an automatic age cutoff, or a decision based on wealth, fame, disability stereotypes, family pressure, or perceived social importance. A fair policy must recognize both truths. We want scarce care to save as many people as possible. We also want every person to remain morally equal when the system is under pressure. The test of medical ethics is not how beautifully we speak when resources are abundant. It is whether we can make tragic choices without turning vulnerable people into lesser human beings. Now imagine those two patients again. One bed, one younger person, one older person. Their medical chances are equal. Should the hospital choose the younger patient, use a lottery, or follow another rule entirely? Tell me what you would decide, and more importantly, tell me why.